I'm going to get started now to welcome you all to our Novo Nordisk Network-BBDC joint research in progress rounds. My name is Dr. Lorraine Lipscomb. I am the director of the Novo Nordisk Network for Healthy Populations and as well as an executive member of the Banting and Best Diabetes Center at the University of Toronto. And these rounds are intended to provide an opportunity for our trainees and junior faculty to give a short presentation, receive feedback and guidance and direction, and share with us the work that they are doing in progress around research related to diabetes and related conditions. So I'd like to start before we begin by acknowledging the land on which the region of Peel operates. These rounds are coming to you from Mississauga and the region of Peel. And we'd like to acknowledge that the land on which the region of Peel operates is part of the treaty lands and the territory of the Mississaugas of the Credit. For thousands of years, Indigenous peoples inhabited and cared for this land. In particular, we acknowledge the territory of the Anishinaabe, Huron-Wendat, the Haudenosaunee, and Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. We're grateful to have the opportunity to work on this land, and by doing so, give our respect to its first inhabitants. We are all treaty people, and many of us have come here as settlers, immigrants, or newcomers in this generation or generations past. So we'd like to also acknowledge those of us who came here forcibly, particularly as a result of the transatlantic slave trade, and pay tribute to the ancestors of African origin and descent. So without further ado, I'd like to welcome you all to today's research in progress rounds. We will be having two speakers, each who will speak for 20 minutes, followed by a 10-minute question and answer session that will be launched by a special guest faculty advisor that the speakers have chosen to provide specific feedback on their proposals. So before I introduce you to today's speakers, I'd like to quickly review some housekeeping items. So we appreciate our audience muting themselves during today's presentation. There will be an opportunity for questions, as I mentioned, at the end of each session, and we will be inviting questions both through the chat box or by using the raise hand function. If you have questions during the event that you would like the speakers to address at the end of today's session, please enter them in the chat box. Lastly, please note that today's session is being recorded, and we will make the recording available on the network's website that will be launched on the network's website. So now I'd like to introduce to you our first speaker, Shadia Adekunte. She is she is currently a second-year medical student at the University of Toronto. Prior to starting medical school, Shadia completed a Bachelor of Medical Science specializing in epidemiology and biostatistics at Western University. And many of her past research and extracurricular endeavors have examined health disparities as they relate to marginalized populations. The title of Shadia's presentation today is Comparing Diabetes Quality of Care and Outcomes Between Ontarian Immigrants and Non-Immigrants Within Dimensions of Marginalization. Her supervisor for this work is Dr. Beju Shah, who's with us as well, and our special guest faculty advisor is Dr. Hussam Abdel Kadir, a cardiologist and clinician scientist at Women's College and the University of Toronto. So without further ado, please go ahead, Shadia.
Okay, let me just making sure you can see my screen. Yep, okay, perfect. So thank you everyone for taking the time to attend today. My name is Shadia Adekunte, and I'm a second-year medical student at the University of Toronto. Today I'll just be talking to you a little bit about some research I've been doing over the past year or so. With Dr. Beju Shah and Dr. Calvin Key, and the title is Comparing Diabetes Quality of Care and Outcomes Between Ontarian Immigrants and Non-Immigrants Within Dimensions of Marginalization. So I don't have any actual or potential conflicts of interest in relation to this program. So the objectives today are to, number one, describe several distinct dimensions of marginalization in Ontario. And number two, understand how indicators of diabetes care differ between immigrants and non-immigrants or long-term residents in Ontario. So to give you a little bit of background, type 2 diabetes has a higher prevalence and poorer management and control in many marginalized communities in Canada. Some of these include racialized communities and recent immigrants. Studies have found that non-white Canadian immigrants, particularly those from South Asia, the Caribbean, Sub-Saharan Africa, and Latin America, seem to experience a higher burden of diabetes, and several factors can affect the diabetes care and outcomes in immigrants. Some of these could be informational, financial, linguistic, cultural, and also systemic barriers. And then there's also this notion of the healthy immigrant effect, where immigrants' health is generally better than those who are Canadian born, though it tends to decline as the years in Canada increase. But the relationship between immigration and health is quite complex, especially because the origins of the immigrants to Canada are from diverse areas. So why is research like this important? Because understanding factors and barriers with the growing immigrant population in Canada is quite important. In 2021, immigrants made up about 23% of the Canadian population. So it is important to recognize any potential barriers to diabetes care that could lead to poor outcomes. So the research question is, among Ontarians with diabetes, does immigration status affect the process and outcome indicators of diabetes care within dimensions of marginalization? And the PICO outline for this, we're looking at population of Ontarians with diabetes diagnosed on or before April 1st, 2019, which was our index date. The exposure was immigration status, and there's several different classes of this, whether sponsored family, economic caregiver, economic other, or just refugees as well. Our comparison group is non-immigrants or long-term residents, so who immigrated before 1985 within the same dimension of marginalization, and I'll explain those dimensions a little bit afterwards. Our outcomes are process and outcome indicators of diabetes care, which I'll also explain afterwards. And the time frame, as I said before, was the index date of April 1st, 2019. Observation window was a year long until March 31st, 2020. So to talk a little bit more about the research design and methods, this is a retrospective cohort study where we linked data from ISIS and the Ontario Marginalization Index. As I said, the index date was April 1st, 2019, which would help kind of take the COVID effects out of it. And then descriptive statistics were done for our baseline characteristics, and also a log binomial regression was done for some of the outcomes, which I'll speak about afterwards. So to give you more information on the Ontario Marginalization Index, or the ONMARG for short, it's a data tool that combines a range of demographic indicators into 4 distinct dimensions of marginalization. It's often used for studying health inequities. So the 4 distinct dimensions include material deprivation, residential instability, dependency, and ethnic concentration. Ethnic concentration is in brackets here because we didn't use that specific dimension in our study, but the top 3 we did use. So to describe material deprivation, it's closely connected to poverty, and it refers to the inability for individuals and communities to access and attain their basic material needs. So this is usually used as sometimes a proxy for socioeconomic status, and it could include indicators such as income, quality of housing, educational attainment, and family structure characteristics. Next, we have residential instability, which is an area level concentration of people who experience high rates of family or housing instability. The indicators included in this are residential accommodations, family structure characteristics, and it could relate to neighborhood quality, cohesiveness, and supports. And lastly, for the study, we use dependency, which is another area level concentration of people who do not have income from employment. So this includes seniors, children, and adults whose work isn't compensated. So these adults might be taking care of households, taking care of people in the community, or might be prevented from working due to disability. These dimensions are organized into quintiles, whereby Q1 is least and Q5 is most. So for example, Q1 is least materially deprived, least residentially unstable, least dependent, and thereby least marginalized. And same goes for Q5, which would be most. So to talk a little bit more about the diabetes indicators that we included, there are two types, the process indicators and the outcome indicators. So the process indicators measure the extent to which patients are receiving good diabetes care. And this is defined by reference to the best practice guidelines for diabetes care. So some of these are having an HbA1c test done, LDL cholesterol tests, retinal examination, so on and so forth. Whereas our outcome indicators measure measure and reflect the impact of the healthcare on the health status of our patients. So we have all-cause premature mortality, which is mortality before the age of 75, hospitalization for long-term diabetes-related complications. So this could be things like micro or macrovascular complications. And then we also have hospitalization for short-term diabetes-related complications. So things like DKA, hyperglycemic hyperosmolar coma, et cetera. And we also have HbA1c, LDL level, and urine ACR level here as well. So now to talk a little bit about the results that we found. So the baseline characteristics of our study population by immigration status, we found that immigration status was on average 5 years younger than, or the immigrant population was on average 5 years younger than the non-immigrant population. So we could say our immigrants are about 60 years old on average. Non-immigrants are about 65 years old. The majority of immigrants were married, so about 70%, as you can see here. And most immigrants also spoke English, about 63%. Next, to talk a little bit about where our populations fell in terms of their quintiles. So material deprivation quintile, which again is closely connected to poverty and socioeconomic status. We could see that it increases for both immigrants and non-immigrants, going from least deprived to most deprived. Compared to non-immigrants, immigrants were also more likely to fall into the more deprived categories. So over here, we can see that our immigrants are in blue, and they were more likely to fall into these categories as opposed to our non-immigrants, and less likely to fall into the less deprived categories, as we could see in Q1 and Q2. Next, by residential instability quintile, we see quite an interesting pattern whereby the highest proportion of immigrants falls into the least unstable or least marginalized by residential status category, but then also we have a higher proportion who fall in, or the second highest proportion falls into Q5, which is the most unstable. So we see that there's a higher proportion of immigrants on the extremes. Non-immigrants tend to had a steadily increasing proportion of people falling from least unstable to most unstable, as we could see here. Immigrants were much more likely than non-immigrants to be in the least unstable category, but also in the most unstable, which I had said before as well. And next, by our last dimension of marginalization, which is dependency, we see that immigrants have a decreasing trend, with most falling into the least dependent category, whereas non-immigrants had an increasing trend, with most falling into the most dependent category. Immigrants were more likely than non-immigrants to fall into the lesser dependent categories, so you could see here, whereas non-immigrants were more likely to fall into the increased dependence categories, as we could see with Q4 and Q5. A little bit more information about the population of immigrants. About 47% had a secondary education or less upon landing, and 42% immigrated under one of the following: so other refugees, refugee claimants, refugee dependents, humanitarian and compassionate cases, and also other immigrants. About 36% immigrated under the economic caregiver class, as we can see here. And the largest proportion of immigrants were from South Asia, so almost 50% of the population with diabetes, the immigrant population with diabetes. And then majority of our immigrants immigrated over 10 years prior to the index date, so 82%. So now we'll look at the process indicators, the proportions for the whole population, and then after by dimensions of marginalization. So anything in blue is our immigrant proportion, anything in yellow is our non-immigrant proportion moving forward. You can see the rate ratios are above. Anything above 1 tells us the proportion was higher in immigrants than non-immigrants, and anything under 1 would tell us the proportion is higher in non-immigrants than immigrants. We could see that the proportions were higher for LDL cholesterol tests and urine ACR tests, having done those within the past year. for immigrants compared to non-immigrants, whereas the opposite was true for having HbA1c, a retinal examination, ACR prescription, or statin prescription, though it's quite minor. So whether these are clinically different is a question. Next are outcome indicators. So these are generally in concordance with general patient targets for lab values. So having an HbA1c under 7, an LDL under 2, and a urine ACR under 2 as well. So having achieved those goals, we could see that it's quite similar in those who are immigrants and non-immigrants, whereas we see immigrants tended to have, were more likely to achieve a urine ACR under 2 for the whole population. And we'll see this trend continue throughout the different dimensions of marginalization as well. So now separated by dimension of marginalization, so specifically material deprivation here. And also you could see that each process indicator has been separated into Q1. As a reminder, that's the least deprived, Q5, the most deprived. We could see that overall, immigrants tended to have higher rates of doing their LDL cholesterol tests and also having the urine ACR test, whereas the opposite is true for things like our HbA1c, having a retinal examination, and the ACR prescription. We could see that the differences get smaller, moving from least deprived to most deprived for HbA1c, also the ACE and R prescription and statin prescription, whereas the differences get larger, moving from our least deprived to most deprived for retinal examination and the urine ACR test. We see very similar trends with our outcome indicator of urine ACR, where immigrants tend to be more likely to have achieved that, as opposed to our glycated HbA1c and LDL cholesterol, which are quite even in the immigrant and non-immigrant population, despite the quintile that they fall in. Next, this is the kind of same thing, but now a new dimension of marginalization, which is residential instability. We could see that similar outcomes whereby non-immigrants had higher proportions of having completed a retinal examination and having an ACE or ARB prescription and glycated HbA1c tests, whereas opposite is true for LDL cholesterol tests, despite the quintile, and also urine ACR tests. Again, we see that just within the dimension of marginalization of residential instability, urine ACR tests tend to be higher in the immigrant population as in the immigrant population as opposed to the non-immigrant population. And the rates are quite similar in glycated HbA1c levels and LDL cholesterol levels, despite the quintile. And our last dimension of marginalization is dependency. And we do see similar trends again, where retinal examination tends to have a higher proportion in non-immigrants as opposed to immigrants. Same for statin or ACE or ARB prescription. And then the opposite is true for having a LDL cholesterol test, and again, the urine ACR test. And lastly, with the outcome indicator of urine ACR under 2, we see that the immigrant proportion, again, is higher, similar to the trends we found in the other 2 dimensions of marginalization as well. So now we'll talk a little bit about the 3 outcome indicators that were adjusted for age and sex using a log binomial regression. And we adjusted for these because we do expect the outcomes to vary with age and sex as opposed to the other ones that might not. So those 3 indicators are premature mortality, hospitalization for long-term complications, and hospitalization for short-term complications. So going back to premature mortality, we see that overall, immigrants are favored and have a decreased odds of premature mortality compared to non-immigrants within the same level or the same quintile of marginalization overall. And we could see that despite the dimension of marginalization, whether it's material deprivation, residential instability, or dependency quintile, they tend to overlap. So there isn't much difference. Next, for hospitalization for long-term complications, we see that there is a significant interaction term here, so that we could kind of conclude that the hospitalization for long-term complications, or the relationship between hospitalization for long-term complications and residential instability is different for immigrants versus non-immigrants. So you can see here that the confidence intervals for Q1, which is our least unstable, versus Q5, which is our most unstable or most marginalized, don't overlap. So immigrants who were the least unstable or least marginalized had about a 29% decreased odds of hospitalization for long-term complications compared to their non-immigrant counterparts within the same quintile. And immigrants who were the most unstable or most marginalized had about a 43% decreased odds of hospitalization for long-term complications compared to their non-immigrant counterparts within the same dimension of marginalization in the same quintile. So that's quite interesting because it isn't really what you would expect, because the immigrants in the least marginalized category compared to their counterparts in the same category are doing worse than those in the most marginalized category compared to their non-immigrants counterparts in the same category as well. And lastly, hospitalization for short-term complications. You can see again that immigrants are favored no matter the dimension of marginalization, and have a decreased odds of hospitalization for short-term complications. So just a quick summary. After adjusting for age and sex, we found that immigrants with diabetes tended to have better outcome indicators than their non-immigrant counterparts within the same dimension of marginalization and quintile. Immigrants did have decreased process indicators of care for specific indicators compared to their non-immigrant counterparts. So retinal examination specifically tended to be less, and also the ACE inhibitor and ARB prescriptions as well. And dimensions of marginalization don't really explain the differences in diabetes processes and outcomes indicators of care. As we saw in the outcomes, they're quite similar. So in terms of future steps with this, potential steps with this research, it could be really difficult to disentangle ethnic differences from those maybe caused by or those that relate to immigration. So that would be interesting to look at the intersection of that. Also, the time gradient and period of immigration could be a little bit difficult to disentangle with the healthy immigrant effect. So maybe we could look into the differences between maybe newer versus older immigrants. So maybe those who are less than 5 years versus more than 10. And also looking at the differences between immigration categories, because there are different levels of support. So for example, private sponsorship refugees may have different levels of support than government assisted refugees. So we could look at how that might affect the diabetes processes and outcome indicators of care. And overall, past research has shown that there's different structural factors that could be in effect, such as racism or anti-immigration discrimination that could have effects on health. So it'd be important to kind of look at the differences. And thank you. Open to any questions or comments.
Shadia, thank you so much for an excellent presentation. You had a lot of data to present, and clearly a lot of interesting information. So I'm going to open it up to questions, and given that we started late, we'll take maybe about 7 minutes of questions. And actually, I'd like to once again welcome our special guest, Dr. Hussam Abdel Kadir, who's agreed to be here as Shadia's advisor. And maybe I'll start. I know there are some hands and some questions, but maybe I'll start with Dr. Abdel Kadir if you have specific questions or comments for Shadia.
Wonderful. Good afternoon, everyone. First off, apologies for being late. It was a clinic that ran later despite me underbooking it. In either case, I echo Dr. Lipscomb's comments. I thought this was a really nice presentation. You did cover a lot of data in a short period of time. I do have several questions that I've sort of put in mind, but maybe I don't want to steal other people's thunders. Maybe I'll let other people go first, and then maybe I'll choose the questions that haven't been addressed by others.
Thank you, Hussam. Okay, Dr. Norris, please go ahead.
Yes, hi, Shadia. I'm not able to turn on the video, but you know what I look like? You did an outstanding job. Congratulations. This is very important for all the reasons that you addressed, the immigration. And, you know, I'm an immigrant myself, and, you know, there's diabetes in the family, so it hits home. I'm wondering, are you able to track the association between access to a family doctor and access to specialists? You know, there are tremendous changes in our healthcare system. And I see, as someone who does provide care to immigrant, francophone immigrant, that access to care is a big barrier to following guidelines.
Yeah, so access to care definitely is a barrier to following the guidelines for several populations. And that's kind of one of the factors that has been identified in the literature in the past. In terms of tracking that with this study, I'm sure that's potentially something that we could add. There's an indicator for it in ISIS. So I'll definitely take that into account, and perhaps that could help explain a little bit of the differences we see between the different populations.
Yes, thank you. And certainly during COVID, we saw that some Black neighborhood had less access. There was fewer density of family doctor, or fewer density of pharmacy, or, you know, lesser access to food stands. So thank you. This is really important.
Thank you.
Great. Any other questions for Shadia? Yes, I have one in the chat here, and I'll also read you a really nice comment from one of the participants, Ethel Makatange. Excellent presentation. There's more and more research being done on determinants of health and chronic disease. Your outcomes are very similar to other research I've seen in the topic. This is useful, as hopefully these findings could be used by government in allocating health funding in regions with marginalized populations, i.e. Scarborough, to support health equity. And I would also add Peel region. We know this is an area that we're currently focusing on for our network. So thanks for that comment. So the question that we have a question from Natasha Anita. Do you have any thoughts on people with extensive immigration history? For example, immigrant in Canada plus years spent as an immigrant elsewhere.
I'm not specifically sure with that. However, if I had to have like a hypothesis, the healthy immigrant effect and these kinds of effects with like barriers to care and acculturation, things like that, I feel like would be similar between immigrants to different countries, specifically because, you know, things like acculturation and getting used to a new place and being able to access health supports and things like that can be different. So there might be different effects, maybe based on, you know, the healthcare system of the country. But overall, I feel like we don't really have information on prior arrival to like Canada. So we only know when they arrived.
There is information on where they came from,
yeah.
But you don't know where they originally came from. I think that's the point.
Yeah.
Dr. Abdelkadir, maybe you can ask some of your questions then.
Maybe I'll address the last point that was brought up, in the sense that you can sort of infer some of that, because there's several variables in the in the immigration database, right? Because you can identify the country of birth, the country of citizenship, and the country that they arrived to Canada from. So I guess you can make an assumption. It may not be, you know, it's obviously an assumption, but you can assume that if all three variables were the same, chances are the person immigrated to Canada directly from their country of birth. Whereas if these variables are different, sort of indicates the person may have moved around before they came there. I do think it's an interesting point. And it sort of, I think, leads to one of the questions that I had, in the sense that you treated all immigrants, you know, the same way, whether they would have immigrated to Canada from Europe, whether they immigrated to Canada from Asia, whether they immigrated to Canada from Africa or South America. And depending on where people come from, their experiences with westernized healthcare and Western institutions may be different. Similarly, I guess, you know, immigrants can also immigrate to Canada through different approaches, as you've seen, like through the economic approach or through family reunifications. So I guess you haven't done this, but can you hypothesize what you think your results would look like if you stratified based on these factors, which parts of the world they came from and their immigration pathway?
Yeah, so thank you for the question. In terms of the kind of disentangling, what I think you're saying is like ethnicity and immigration status, which we know that typically non-white Canadian immigrants, so those from South Asia, Caribbean, Sub-Saharan Africa, Latin America, seem to have like a higher prevalence, higher burden compared to those who come from maybe like Europe. So that would be my hypothesis. And I feel like, you know, because we don't really collect ethnicity data, race-based data, it might be difficult to kind of disentangle. And just because somebody maybe immigrated from South Asia or the Caribbean might not mean that they're specifically South Asian or Caribbean in ethnicity. So I think it could be really difficult to disentangle that, but hopefully in the future we'll be able to look at those specific factors and their effects.
Gotcha. Now, what about the other issue, the immigration pathways to Canada? Do you think that would be something where you would expect to see consistent signals as you saw here, or do you think there may be some differences?
Yeah,
there?
so we do actually have like the separated data, and hopefully in the future kind of look in the future look at the stratified data specifically. I do think though that those who are supported, so maybe like privately sponsored refugees might do maybe a little bit better off. That's just like a hypothesis. I'm not specifically sure. But I think, yeah, those who maybe get support from family might be a little bit better off than those who do not.
Okay, great, awesome. I could keep asking questions, but I see Chris.
Yeah, and Hussam, thank you so much for your questions, and I'm sure you've got lots. And if there's time, maybe if you have a little bit of time at the end, maybe you can connect a bit longer with Shadia, but I want to make sure the second speaker gets a chance to speak as well. It's just always like that. We always have so much to discuss. But Chris, maybe if you have a really quick comment, and then we, as Fatima is setting up her slides, please go ahead.
Yeah, just on the odds ratios for lower hospitalization, for short and long-term related complications, it's on its face, it seems great to be less likely to be in a hospital. I certainly would not want to, you know, I'd like to be among that group that's not in the hospital. But how would you think about and control for possibility that it's just harder to get a hospital bed for immigrants when a hospital bed is actually appropriate and would be beneficial?
That's a really great question. I think it's kind of similar to what Dr. Norris had asked in terms of having access to care and being able to control for that. I think it's a good suggestion, and I'm not exactly sure how we would be able to do that. But hopefully something I could kind of take into consideration.
Thank you. Yeah, no, that's right, Shadia. There may be ways indirectly, but I think we have to move on. Thank you, everyone, for your comments, and a special thank you to Shadia for a fantastic presentation. Really well done. So now it gives me great pleasure to introduce our next speaker, Fatima Ali. She is one of our very own research coordinators with the Novo Nordisk Network for Healthy Populations, but she is also she also just recently completed her master's in medical anthropology with a collaborative specialization in women's health at the University of Toronto. And she has a lot of experience conducting community engaged projects that have focused on understanding how chronic diseases, health systems, and policies impact people. Her graduate research project that she will be discussing today is focused on understanding the experiences of Black women living with diabetes through studying the intersection of health, race, gender, and socioeconomic status. And the title of her presentation is The Healthcare Experiences of Black Women Living with Diabetes in Toronto, Ontario. Her supervisor was Cassandra Hartley, and we're pleased that Dr. Beju Shah, who's with us today, has agreed to be her faculty advisor. Please take it away, Fatima.
Thank you for that introduction. Hello, everyone. My name is Fatima, and today I'm going to be talking about my master's research project that I completed at U of T. So today I'll be discussing the healthcare experiences of Black women living with diabetes in Toronto, which I did this project under the supervision of Dr. Cassandra Hartlow. So I added this disclosure statement that I don't have any potential conflicts of interest in relation to this project. So today I wanted to start off by discussing why I decided to focus on Black women living with diabetes. And so in Canada, African, Caribbean, and Black communities have a higher prevalence of diabetes. And it's been found that there are a multitude of factors that put women in Canada at a higher risk of developing this condition. So through applying an intersectionality perspective, which aids in this understanding that certain identities and social determinants of health, such as socioeconomic status, education, do not exist separately, but they actually intersect, which can result in varying illness experiences. So it's important to understand that the totality of a person's identity impacts how they develop and manage a health condition. The population I decided to focus on was Black women because the risk factors that put individuals at high risk are further compounded by racial and gender inequities, among others. So it's important to understand what's going on and why are things going on and that my background is in qualitative research. So these were all I did this work through doing interviews. So this project was conducted in the Jane and Finch community. So it's located in the northwest part of Toronto. It's made up of two city neighborhoods, so Black Creek and Glenfield Heights. Both neighborhoods have higher levels of individual low income per each age group than the rest of Toronto. Also, in terms of ethnocultural diversity, both of these neighborhoods have a higher percent of visible minorities, and the highest visible minority population in these communities are Black individuals. And also, this community does this community has a high prevalence rate of diabetes compared to other regions of Toronto. And as we know, high blood sugars, when they're left unmanaged, they can lead to very severe and potentially very severe complications. So also, when I was initially thinking about what I wanted to do for my master's project, and I was doing like an initial literature review to see what research has been done in this field, I found that there was lack of both qualitative and quantitative research done on diabetes in Black communities in Canada. So I found it demonstrated to me the importance of prioritizing populations that tend to be overlooked and under-researched. So for my research objectives, this was to understand how Black women living with diabetes in Jane and Finch manage their condition. So both through accessing healthcare as well as how they do self-management, to identify gaps and possible solutions to support this community, and moving the conversation away from compliance versus non-compliance, but rather identifying what barriers and facilitators do they identify and which ones have they experienced. So when I'm going to be discussing my findings, the conversation is going to be centered around what were the barriers and what were the facilitators that were identified. Also, another objective that I have is to share the findings with healthcare providers, policymakers, community members, and healthcare organizations to ideally prompt action. I did this project with a community health center, that's that Black Creek Community Health Center. They have a specific catchment area where Jane and Finch is within, and they have a diabetes education program. A CHC, as you know, is a nonprofit and publicly funded. And they also serve everyone regardless of immigration status as well as insurance status. And they provide various services under one roof. So they provide primary care, health education, social work, access to social workers, dietitians, specialists, and other community services as well. So when I was initially trying to figure out how to do this work and how to approach this, it was very clear that, as I mentioned, like doing this research project, this research topic was very under-researched. However, it engages with a community that tends to be very over-researched. And this was also indicated to me by the CHC when I initially was doing my initial interactions with them. And so it demonstrates that you have to do thoughtful engagement and partnership, and also make sure that the project findings do benefit, or whatever comes from the project also benefit the community, and that the research doesn't just leave afterwards. So I had the opportunity to actually work within the CHC for a 1.5 years before starting my field work. And this truly was invaluable in the sense that it provided me a lot of background on how does the CHC function, how do patients and clients interact with the CHC, and it very much informed how my interview guide as well as how I approached doing the work. So I engaged with the CHE to identify research priorities and also provide input on the interview guide as well as my REB application that I ended up submitting. I also had discussions with the chronic disease team as well as the primary care team to provide feedback on the project as well as to inform my recruitment strategy. So for my methods, I had the opportunity to interview 6 community members. They were all residents of Jane and Finch. They identified as being Black women, and they were between the ages of 35 to 60. They were diagnosed with type 2 diabetes, and they were clients of the CHC. 4 women were from the Caribbean, 1 was from West Africa, and 1 was from East Africa. I also had the opportunity to interview 6 healthcare providers that also practiced within the CHC. And one of my stipulations was that they must have been practicing within this community for at least 5 years. And they were from various healthcare professions. So I interviewed a doctor, a nurse practitioner, a registered nurse, a dietitian, a kinesiologist, as well as a chiropodist. For data collection, I did semi-structured interviews. So this included open-ended questions, and the conversations were mainly led by participants. This led me to having 40 interviews over 6 months with my 12 participants. And this truly allowed them to, it gave them space to provide personal narratives as well as context to the answers to the questions that they were providing. I also did participant observation. So I attended diabetes education sessions. So the CHC offered diabetes support groups as well as nutrition education programs. And I also attended I also observed healthcare team meetings, so specifically the chronic disease team meetings within the center. In terms of analysis, I did qualitative coding. So I did an inductive and deductive approach. So that means that based on my interview guide, I created a code book based on that. And then as I was doing the analysis, I added to the code book based on themes that started emerging. So for the results, today I'll be discussing specifically the facilitators and barriers that are identified by the healthcare providers and community members as related to healthcare experiences. So the first facilitator is the access to health services, but not only services, but specifically the type of services. CHCs are based on integrated and interconnected healthcare, and which also is referred to as comprehensive care. So when a client once a client is diagnosed, for example, with diabetes, they receive support from their primary healthcare provider, which provides, which ensures that the management of their overall health as well as their continuity of care. They might have access to a community health worker who will help them with navigation and connection to support services, a social worker who will provide mental health support and advocacy, and they'll also have they'll have access to a diabetes care team. So this will include a diabetes educator, a kinesiologist who will support with exercise management, as well as a chiropodist to treat possible diabetes complications. They will also have access to food security programs, so food vouchers, food bags, and food hampers. This was a quote that was shared with me by one of the healthcare providers that I interviewed. So she stated, we identify those women at risk and then do some health history with them, some physical assessment, and then do the blood test just to confirm or exclude diabetes. If it is confirmed as a primary care provider, it is my responsibility to put in place a treatment plan in collaboration with my client. So it's more like sitting down with the client, informing them or communicating the diagnosis to them, the treatment options, and then they choose the one that will suit their lifestyle. So this quote demonstrates what happens when a primary care provider is providing care to one of their clients that that might be at high risk of developing diabetes. And this demonstrates how they include the client in the treatment plan, that it gives the client the opportunity to be an active participant in their care. This was one of the other quotes that was shared by another healthcare provider. They stated, I'm lucky to work in a community health center, to have an entire professional practice where they have primary care, they will have a diabetes education team, which is a registered nurse, and also a dietitian and foot care. This quote highlights that not only is the patient supported, but also the healthcare provider also felt lucky to be working on this team. The sentiment was shared by the other healthcare providers and service providers that I interviewed, that they knew that they had access to other providers, so that they knew that they weren't the only one providing care for their client, and that they knew what would happen next in terms of when their client left their room. Another facilitator that came up during the interview with community members was the impact of access to information and education about their health condition. And how this had an impact on their preconceived understandings of diabetes. A question that I asked both my healthcare providers as well as the community members that I interviewed was, what does diabetes mean to you? And you can imagine that the healthcare providers provided a biomedical definition, but these were the quotes that were shared to me by the community members. So one of them said that that's all it means to me. Like, you know, it's a big, big lifestyle change. Culturally, it means a death sentence. It was shocking. It was one of my biggest fears. It means a death sentence, a drastic change. That's what it meant initially. It meant death. It was like an old people's disease. When I was diagnosed, it was a little bit embarrassing for me. But something that became apparent was that as the conversations continued and they continued to share, they demonstrated how their narrative shifted and that they no longer understood the condition to mean these things, but rather that it shifted to being something more manageable. And so how did they get to this point? How did they start understanding their condition to be manageable? And they attributed this to access to a large healthcare team who provided them access to information, but also gave them access to their time. I think they compared their experiences to previous healthcare experiences where they would only have 15-minute appointments with their healthcare providers versus this time they'd have multiple different providers providing care for one healthcare condition over multiple appointments. And they'd also get access to various perspectives as well. So now I'm going to move on to some of the barriers that were identified. And the barriers that were identified tended to be connected to the financial challenges of managing diabetes. So specifically in these three areas. So management of related to lifestyle changes, so healthy eating, physical activity, attending appointments, and managing stress. Also in terms of pharmaceuticals, so oral medications, insulin and pen tips, and testing supplies, so glucometer, lancets, and test strips as well. And the treatment, as you can see, like the treatment of diabetes, it becomes a lifestyle change, but it involves both life changes to habits as well as financial costs. Some of the women I interviewed had to make the choice between paying rent, feeding their children, paying bills, buying medication, or buying healthy foods. And when you can't afford to manage your health, it has dire consequences. And this following quote was shared with me by one of the community members I interviewed. So she shared with me, my sugar was out of control, so I couldn't even read it on the meter. I was in a coma, I couldn't talk, I couldn't walk, I couldn't do anything other than be in a wheelchair. I wasn't testing on a regular basis. I wanted my 100 strips to last me more than a month. So I was testing just, maybe I'll test this week, maybe I'll skip 2 weeks, but I wasn't testing every single week. When I got into the coma, before the coma, I was trying to make my strips last. So the specific barrier that this participant identified was that the test strips that she would insert into her glucometer would only come in packs of 100. So she'd have to pay $100 in one go. And sometimes that was too much for her. She was trying to make that last as much as she could. And I asked her, what would the impact have been if she did have access to free strips? And this is what she said. She said, if I was getting free strips, I don't think the money would have been an issue. Because if I get a free strip, I'm not going to be like, oh, I'm trying to stretch my $100. I'm not going to be thinking that because I don't have to pay $100 every single month. I'm not going to be thinking that because I don't have to pay $100 every single month. Sorry. If the strips were more reasonable, that wouldn't have happened to me and I wouldn't have ended up in the hospital. For this quote, we can see that a healthcare provider just telling a patient to test their blood glucose level multiple times a day or a week, it might be what they need to do, but it might not, just saying that isn't enough, especially if the client or the patient doesn't have the means to buy these test strips. This was another quote that was shared by one of the participants. They said, if it is one of those things where you have to figure it out, if I buy medication this month, or do I try to do something else with the money, Like I've had days like that. I really and truly humble myself and ask somebody if they can buy me the medication. I've had times like that, like I really can't afford it and I really do need it. And people who know me know I don't definitely ask unless I really need to. So you can see from this quote that not only do you have to worry about the diabetes, but you also have to worry about how you're going to afford your health. And when you don't have the means to cover these costs, it puts you in a precarious situation. So some key takeaways in terms of some facilitators that were identified that I went through, include access to integrated health services, and which include a robust care team as well as access to information. Some of the barriers that were identified during the interviews, which mainly related to financial challenges, specifically the cost of management tools, were what was identified by both the healthcare providers as well as the women that I interviewed. So comprehensive diabetes care, what does this look like? I think something that became very clear during my interviews is for it to be truly comprehensive, it needs to include both access to healthcare as well as access to tools that are needed to manage the condition. And it can't be either or, but it needs to be, you need to see it from the perspective of the clients who are the ones who are going to be dealing with this. And they're the ones that are going to be ultimately falling through the cracks. So in terms of some next steps that I did, or I'm hoping to do and planning to do with the work, the recent interviews that I conducted, is developing an accessible infographic, which hopefully will be shared with my participants, the community health center, as well as other healthcare organizations. I developed a policy brief, which I'm hoping to validate and confirm with the diabetes team and share that. That's going to be shared with the participants, community health center, as well as other organizations. And I went back to the CHC and I asked them, in terms of presentations, what would make the most sense? And they highlighted the need for targeted and relevant presentations. I have about 40 interviews and many hours, those which include many hours of transcripts. Something similar to what I did today during this presentation is I tried to figure out what would be the most useful to the audience. So something similar to this, where I'm going to be going through those the transcripts and figuring out what would be relevant to, for example, the chronic disease team versus the primary care team versus the community health workers. So trying to make sure that each team is receiving relevant information. Also presenting to diabetes groups as well as other health organizations and to the community. For some advocacy work that I've been involved in is I'm currently the chair of the Black Creek Community Health Center Research Advisory Committee, which we've been in the process of developing internal research policies as well as advising project improvement strategies and knowledge translation. So I've been trying to apply my experiences with what I've been both, and I'm a resident of Jane and Finch. So being a part of the community as well as a researcher, I've been trying to provide some information around what would work, what doesn't work, or some advice in terms of that. And for knowledge translation, hopefully we can develop some internal methods to share when a researcher does come, that we give them the tools they need to share back with the community as well as to share back with the center. Also, I'm hoping to collaborate with Black Creek Community Health Center to ensure project findings inform initiatives and programming. They're currently in the process of developing a diabetes virtual care project. So I'm hoping that I'm going through my interviews to see what did participants say about virtual care, and hopefully that can be applied to what they're going to be doing. So yes, thank you, everyone.
Fatima, that was a fantastic presentation and so well presented and such great work. Congratulations, and thank you so much for your wonderful advocacy for this group. I'm going to open it up. There may be some questions, but the first thing I would like to do is ask if Dr. Beju Shah is available as our faculty advisor, perhaps to launch some questions or comments.
Thanks very much, Lorraine, and thanks, Fatima, for a great presentation. We've chatted about your work from time to time, but it was nice to actually hear it in such detail like that. That was really, really excellent. I guess, and this sort of ties into some of the questions that have come up in the chat as well. But you know, the facilitators that your clients identified were really around integration and team-based care and all of that. And that's really a unique feature at a CHC, which isn't going to necessarily be available to all patients in all settings. And particularly, you know, with our work in Mississauga and Peel, we know that those just don't exist. So how do you have sort of hypotheses about how your findings might have been different if you'd been not in a CHC, but working in a different kind of a environment? Would they have had any facilitators, or would there have been other things that were facilitators for them?
Yeah, absolutely. I initially, when I first proposed my project, I wanted to do like two groups, like those that have access to CHC versus those that don't. But I was reminded that I'm only one person and it was a master's project that I couldn't do all the things. But I know that I was actually a receptionist at a local, a walk-in clinic that was in Jane and Finch for, I think it was like 5 to 6 years, like from high school all the way to like undergrad. And I can only imagine, and the women that I also interviewed, they had stories of like the story before they arrived. at the CHC. And it is the most ideal form of care that they could receive in terms of comprehensive, it being integrated. And in a perfect world, it would be like those models of care would be expanded. I know there's a push to expand the Ontario health teams as well. So I'm hoping that, right, like being able to share the stories from these women, that this will be another form of advocacy to say that it does work and these women are having good experiences and it is reflected in their diabetes management. So yeah, so I'm not sure if that answered the question, but I know definitely this would be very different if I spoke to a group that only accessed walk-in care versus a solo practitioner, a family doctor versus those that don't receive care at all. Like the findings would be very, very different.
Yeah, that's great. There's a lot of questions flying in the chat, so maybe I will hold off asking any more for now.
Yeah, no, you've got a lovely, so many positive comments, Fatima, in the chat, a lot of great comments and suggestions, and I won't read them all in the interest of time. Maybe I'll just focus on where there might be questions, but we will ask perhaps Lydia to make sure you get a chance to read some of the really good and provocative and well-written comments. So let me just see, Krista has a great question here. So researchers are often asked to include diverse communities in a project, but you raise an excellent point about how we often don't consider the burden on them or the importance of integration into a community. Do you have suggestions for how research teams can do a better job in doing this? I guess we can't always work as receptionists, but there may be other ways, right?
Yeah, that's, I think I was in a very unique situation in terms of where I was in my career and I was able to do that type of work. But I think something that I've seen consistently, or when I was initially engaging with the community health center, is that researchers come to them at different stages. Some of them come with fully developed projects and they're like, we just need recruitment, versus others that come at the very early stage and they're like, we have this idea, but we want to make sure that it is relevant. And in a perfect world, if I had more time, I would have loved to interview the community members that engage with the community members that I was planning on doing the project with. But I think the first step is understanding that when you know that you are engaging with a population that is over-researched and on a topic that is under-researched, that you need to center them in the project in terms of how you do recruitment, how you do the research team that you're building, that you make sure that they are, like they might be in a perfect world, you might have somebody from the community on your research team that's able to provide advice with lived experience. So yeah, so there's definitely a lot more thought you should do in the pre-planning stage.
Well, it sounds like there are, a lot of opportunities to build on this work. And certainly, we can talk about opportunities further as we work also in our work in the network. There was even a comment from Dr. Norris in the chat that she's been working with the Centre Francophone, where they have Afro-Caribbean French seniors and adults with diabetes, and thought it might be interesting to compare what you found with the work at that population. So lots of really interesting ideas and places to build. So I think we're out of time. So I am going to ask everyone to please join me in congratulating both our speakers, Shadia Adekunte and Fatima Ali, for fantastic presentations, really, really impactful and relevant work. And we're really excited to see the next steps and see this work being shared and published and having impact. So, and thank you for all of you who participated, and a special thank you to our faculty advisors, Drs. Hussam Abdelkadir and Dr. Beju Shah. Just to let everybody know that our next event will be very exciting. It will be on May 15th, 2023 from 12 to 1. And we will be inviting Dr. Valeria or Val Rack from University of Toronto and Diabetes Action Canada, who will be speaking about her work around helping to improve complications for people living with diabetes. So once again, thank you everyone for joining, and we wish you a wonderful afternoon.